Okay, let's jump straight into part 3 of our explainer series. Frequent falls, clinical features, red flags, and structured assessment. For those of us working at the deep end of multisensory balance disorders, you already know falls in older adults are incredibly complex. Today, we're taking a high-yield patient history and translating it straight into actionable assessment frameworks. We need to pinpoint the exact sensory failure that's driving your patient to the ground.
Now, this explainer is based on the comprehensive literature review titled Frequent Falls in the Elderly, a vestibular physician's deep review of multifactorial fall risk, assessment, and prevention. It's published by Australian Dizziness Clinics, and you can find the whole thing over at australiandizzines.com.
Here's our quick roadmap for today. We're covering 5 key areas. 1. Symptom patterns by mechanism. 2. Identifying clinical red flags. 3. The structured assessment protocol. 4. Standardized performance measures. And finally, 5. The mandatory physical examination.
So think about this scenario for a second. A fall while rolling in bed, a fall within seconds of standing, and a backward fall on turning. On paper, someone might just code all of these as a generic mechanical fall, right? But clinically, no way. These are 3 entirely different diseases. The history, not the MRI, not the CT scan, tells you exactly which mechanism you're actually treating. A detailed history is, without a doubt, your absolute highest yield diagnostic step.
Let's get right into Section 1, Symptom Patterns by Mechanism.
There are some incredibly sharp contrasts between distinct fall profiles, and this is where we separate them out. Vestibular falls famously follow head movement, like looking up or just rolling over, and they're often accompanied by brief vertigo or oscillopsia. Contrast that with orthostatic falls. Those typically hit about 30 to 180 seconds after standing up, and they're notoriously worse in the morning. Then you've got Parkinsonian falls, which present with that classic retropulsion or freezing, especially on carpet transitions. And neuropathic falls? They bring a really characteristic foot drag that worsens profoundly in the dark. Why? Because the patient has literally lost their ground contact feedback.
Moving right along to Section 2, Identifying Clinical Red Flags.
Now, any of these urgent red flags demand your immediate action. If there's a loss of consciousness, even if it's transient, you have to suspect an arrhythmia or syncope. That makes an ECG and ambulatory monitoring absolutely mandatory. A new focal deficit? That implies a stroke. Posterior fossa symptoms, like a sudden occipital headache with diplopia or ataxia, require urgent MRI imaging. And we can't forget a prolonged long lie. Being stuck on the floor for over an hour. That brings massive, life-threatening risks of rhabdomyolysis and pneumonia.
So the crucial takeaway here is this. You should never, ever accept a generic multifactorial falls diagnosis when these high-risk red flags are hiding in your patient's history. These features override everything else on the table until serious cardiac or neurological emergencies are decisively ruled out.
That brings us to Section 3, the structured assessment protocol.
You see, the internationally concordant structured falls assessment algorithm is designed to leave absolutely no stone unturned. You don't just pick one domain and call it a day. It integrates the history, the physical examination, and standardized performance measures to identify literally all modifiable risk domains. Whether you're following NICE guidelines or the AGS/BGS World Falls guidelines, the pathway is identical. Screen, assess holistically, stratify the risk, and implement a multi-domain management plan.
Next up is Section 4, Standardized Performance Measures.
The foundational measure we use here is the Timed Up and Go test, or TUG. The magic number you need to remember is 12. A time of over 12 seconds explicitly flags your patient for high fall risk. It's quick, it's validated, and it is remarkably reliable at predicting injurious falls. Now here's where it gets really interesting. Adding a dual task condition, like asking the patient to count backwards by 3s while they walk, captures vital executive motor deficits. If their time suddenly drops off a cliff, or if they actually stop walking just to think about the math, you've just uncovered a massive cognitive motor coupling deficit, and that is highly predictive of future community falls.
Furthermore, the Short Physical Performance Battery, or SPPB, is another critical tool in your arsenal. A score of 9 or below out of 12 doesn't just predict recurrent falls, it strongly predicts subsequent hospitalizations and nursing home placement. It's an incredibly powerful prognostic number that you really need documented in your chart.
You'll also want to leverage comprehensive tools like the Berg Balance scale, where a score under 45 flags risk, and the Dynamic Gait Index, which uses a cutoff of under 19. These are essential for tracking the patient's rehabilitation progress over time. Honestly, these are the exact metrics your vestibular physiotherapists are going to use to prove that your interventions are actually working.
Which leads us to Section 5, the mandatory physical examination.
This structured sequence is absolutely mandatory to build a complete clinical picture. First up, you have to measure lying to standing blood pressure at both 1 and 3 minutes to catch any orthostatic hypotension. Second, perform the Dix-Hallpike maneuver because BPPV is quite simply the most prevalent treatable vestibular cause of falls out there. Third, execute head impulse testing to check that vestibulo-ocular reflex. And finally, test their sensory dependence by putting them through the Romberg test on a compliant foam surface.
But we're not done yet. You must complete the assessment by checking the other sensory and systemic pillars. Check ankle proprioception using vibration and joint position testing. Run a quick cognitive screen like the MOCA. Assess their cardiac rhythm. And crucially, utilize a Near-Snellen chart to check their vision. Think about it. If they already have vestibular and proprioceptive deficits, they're relying entirely on their eyes to stay upright. If their near vision is poor, a fall isn't just likely, it's pretty much inevitable.
In Part 4 of this explainer series, we're going to cover investigations and differential diagnosis. We'll talk about how to order tests with a specific question already in your mind, and how to accurately name the dominant driver among the vestibular, cardiovascular, and medication-related causes of falls.
Before we wrap up today, I want you to ask yourself a pretty critical question. If your patient falls tomorrow, are you going to accept the easy, vague, multifactorial label? Or will you use these exact tools we just discussed to uncover the real mechanism? The history and a highly targeted physical exam hold the answers.
For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this explainer series, head over to AustralianDizzinessClinics.com. And please subscribe to the channel and leave a rating to support the series. See you in the next one.